Good afternoon, everyone, and good morning to those joining us from out west. Welcome to today's webinar on preparing future and current health professionals to address substance use in our communities. Thank you so much for joining us. A couple of housekeeping items before we get started. This presentation will be recorded. You will get a copy of the recording after the presentation in your email. You will be in listen-only mode for the duration of the webinar, but please do submit questions on the right side of your screen in the box that you can see on the right. And please do connect with us on social media. My name is Cyril Adam. I'm a Senior Director for Health Programs here at Kognito, and I will be moderating today's webinar. It's my pleasure to introduce today's speakers. We will have John Orwatt, Associate Professor at Loyola University, Chicago. Dr. John Orwatt teaches courses in health policy and behavioral health policy and is the principal investigator on the SBIRT at LUC, a SAMHSA-funded interprofessional training grant, and has served as principal investigator on the recently funded HRSA training grant related to interprofessional approaches to integrating behavioral health into primary care settings. We will also have Dr. Glenn Albright, co-founder and director of research at Kognito. Dr. Albright leads a team of researchers here at Kognito in evaluating the efficacy of its immersive learning and assessment role-play simulations to bring about sustained behavior changes in the areas of social, emotional, and physical health. So I just wanted to first set the stage a little bit for today's conversation. First of all, a few words about Kognito. We are a health simulation company based in New York City. Kognito role-play simulations enable organizations to rapidly build the capacity of health professionals, consumers, and caregivers to lead real-life conversations that improve social, emotional, and physical health. We offer a subscription to online evidence-based learning simulations and services to support implementation, program usage, and evaluation. Kognito is also the only company with health simulations listed in SAMHSA's National Registry of Evidence-Based Programs and Practices. To set the stage a little bit for today's conversation, we wanted to talk a little bit about adolescent substance use in the U.S. In 2017, according to the most recent data, 20% of adolescents ages 12 to 20 used alcohol. 15% of adolescents 12 to 17 smoked cigarettes, and another 1.5% used smokeless tobacco. 8% of adolescents ages 12 to 17 used illicit drugs, and 3.5% misused opioids. This carries many risks and consequences. Risks to brain development, to physical and mental health, socioeconomic consequences, and addiction. We saw 72,000 overdose deaths in 2017. And it's useful to remember the pyramid on the right, which shows that the majority of people use substances at no or low risk. And today we will talk about approaches that can address not only risky use or substance use disorders, but the whole spectrum of substance use from both a preventive and treatment perspective. The method a method used to do this is SBIRT, which stands for Screening, Brief Intervention, and Referral to Treatment. SBIRT is an evidence-based reimbursable practice used to identify, reduce, and prevent problematic use and dependence on alcohol and drugs. The process is you would first screen a patient using a validated questionnaire, using those questions as they are written. And depending on the result of the questionnaire, you would provide either positive reinforcement or a brief intervention using motivational interviewing, which can be as short as 7 to 10 minutes, or a brief intervention and brief treatment, which would be an expanded form of brief intervention, or for high-risk patients or those with diagnosable disorders, a brief intervention and a referral to treatment or follow-up care. This is a process endorsed by many federal agencies as well as professional associations, and yet we see in the field very few chances for health professionals and paraprofessionals to learn and practice SBIRT outside of specialty programs. This constitutes a huge missed opportunity to identify substance use and to intervene early before disorders appear. In order to respond to this need, we created SBI with adolescents, which is a simulation that allows you to learn and practice applying evidence-based techniques to screen adolescents for substance use, conduct brief interventions, and coordinate referrals to treatment or follow-up care. And so through this simulation, which I'll show you in a second, learners have the ability to learn about the SBIRT process and then to practice and assess their competency in navigating these conversations with virtual patients that you can see on the right-hand side of the screen. So this simulation includes 3 scenarios, and I'm just going to briefly show you one of those scenarios. So here we'll have a conversation with Josh, who is in the ED after falling off a roof during a party as he was drinking with his friends. And so we'll want to have a conversation with Josh to talk about the role that substance use played in his injury. So let me play this so you can get a sense of how it goes.
Hi, Josh. I'm the social worker that Nurse Lopez mentioned.
Yeah.
How are you feeling?
Well, I've been better.
Oh, I'm sorry to hear that. Mind chatting with me while we wait for your x-rays?
I don't know. I'm pretty slammed today.
So, yes, you can talk?
Yeah, sure.
And we'll first want to build some rapport with Josh, rather than just jump into a conversation about substance use.
So just to help me get to know you a little better, what kinds of things do you like to do for fun?
Well, you know, there's like nothing to do in this town. I hang out with my friends.
What kinds of things do you do when you hang out?
We chill, play video games or whatever, some pick up football.
You like to play video games and football with your friends. Are you on the school team?
Yeah. Next year I should go varsity.
Okay, and we're now in the conversation environment. You can see on your screen that you will be able to talk with Josh using the talk button in the top left corner, which will reveal an array of effective and ineffective options that we can choose from. In the bottom of our screen, we can see our brief intervention checklist, which shows at any given point what our tasks are in this phase of the conversation. And then on the right, we'll be able to monitor the patient's engagement, which will kind of translate the patient or client's reaction and how engaged they are in the conversation. So let's try this out. We can first jump into giving advice, for example, which is something that a lot of professionals would think is the right thing to do in approaching this conversation. So let's talk about the dangers of drinking for Josh and see how that plays out.
On the form you filled out, you said you regularly drink.
And here comes the lecture in 3, 2, 1.
I don't want to lecture you. It's just really dangerous for someone your age. I mean, look at what happened today.
Oh my God, you're right. It'll never happen again. I'm so glad you were here to set me straight.
And here we'll have the virtual coach come up to let us know that we jumped into giving advice to Josh a little bit too quickly without first trying to engage him in the conversation. And so we'll have a reminder to use open-ended questions and other motivational interviewing techniques to really engage him. So we're going to undo what we just said and try a different option. So we can try to engage them a little more positively, for example, by asking for permission to talk about the topic. We could also wag our finger a little bit and say, we need to talk about your answers on the screening form. So let's see how that would go.
I saw your answers to the substance use questionnaire about alcohol and drugs, and we need to have a talk about it.
Here it comes.
Again, you can see that Josh is a pretty typical teenager, and again, didn't respond well and gave us a little bit of attitude with this choice that we made. So we're going to want to ask for permission to talk about his responses, and we'll see how well that works.
I noticed you filled out the questionnaire about alcohol and other drug use. We ask all of our patients to complete that. Thank you for being honest on it. I'd like to talk with you for a few minutes about your responses. What do you think about that?
Oh, okay, I guess.
Okay, we're doing a little bit better. Josh is not, very warm to this conversation, but he's opening up a little bit. And here you can see above Josh a thought bubble. The intent is to improve the learner's emotional intelligence and to be able to tell or predict what the client might be thinking or feeling at any given time. So let's see what Josh is thinking.
I didn't think anyone would look at that thing. Maybe I shouldn't have been so honest.
And you can hear Josh's concern around privacy, which is something that will always come up with adolescents and which we will have a chance to address in this conversation. So let's ask Josh what he thinks the role of alcohol in his injury was.
So how does alcohol factor into the accident tonight, if at all?
I figured you were going to ask that. Look, am I going to get in trouble for writing that stuff on the form? Or for telling you any of this stuff?
Everything you tell me will be confidential, unless I hear that you're harming yourself or someone else, or you tell me that you've been a victim of abuse. I'll keep our conversation about your alcohol use between us, unless you agree to include your parents.
Okay. Look, I definitely had some beers, but not even that much. And I just had like 5 slices of pizza, so it was no big deal.
Hey, that's okay. I am not here to pressure you in any way. I'd just like to help you avoid situations like this in the future.
Oh, okay.
Okay, so Josh is a little bit reluctant to accept the suggestion, but he's warming up and he's friendlier in the conversation. I think you can see how approaching this conversation a little bit differently from the way we would normally do it will really help engage him and help him open up to the topic of substance use. So in this simulation, you will have the ability, as I mentioned, to interact with 3 different patients in various contexts. And at the end of the simulation, the learner will be able to monitor their performance and look at their performance dashboard where they will be assigned an overall score which is composed of different components. One is the motivational interviewing style, so how you approach the conversation and whether or not you stuck to motivational interviewing techniques in doing so. And then on the right, you can see a whole breakdown of the conversation and each step of the brief intervention, and you can see what you did well or less well. And so this will really help learners hone their skills. They will be able to go back and practice this conversation in order to improve their score. So having set the stage for this conversation, I want to pass it on to Dr. Glenn Albright, who will talk about some of the rationale for this approach to training and assessment, as well as some of the effectiveness data that we've been uncovering. Dr. Albright?
Thank you very much, Cyril. If you have the next slide, please. So here you can see that as a learner that you're placed in a virtual environment and you're engaging with Josh, a virtual human that's been coded with emotions, memory, personality, and will react like a real person in this case where you're concerned about their alcohol use. This involves situational learning where you have an opportunity to try different conversation tactics. Some of them are effective and ineffective. These conversation tactics were determined by subject matter experts, by end users, again, all the right things and the wrong things to say. And we kind of want to allow you the opportunity to say the wrong things because it gives you an opportunity to learn. And then, of course, we have this undo where you can go back and try again so you get a better understanding of why that was the wrong or, in some cases, the correct decision. And to facilitate the experience, as you saw, you have a coach that will come in there and give you reasons why you should select another conversation tactic or reinforce good decisions, as well as engagement meters and the nonverbal feedback of the character. You may see him shrug his shoulders and the tone of his voice and so on, all giving you a realistic experience in an environment that represents where you're going to have these types of conversations very often. Also, please notice that this is a private experience. You are not having a conversation or a practice conversation or role play with an instructor or with other people around listening, judging, observing. And being that it's a private role play, you're more likely to be yourself. As a matter of fact, there are numerous studies that show that you and I have a tendency to feel safer and are more likely to open up on how we really feel, what we're really thinking with virtual characters. We're more likely to feel less judged, to experience less anxiety or social evaluative threat that many of us will feel in a real live role play. The learning is scaffolded. That means the earlier conversations where you're learning to integrate evidence-based communication strategies are a little bit more basic and elementary, and as you move through the conversations, it requires you to have more and more skill. That, coupled with ongoing feedback and a high fidelity, allows you really to transfer that learning experience home. And what I mean by fidelity is that the training can be repetitive in terms of giving you accurate information. These virtual humans never age, they never get tired, they're culturally sensitive, so the learning experience is repeatable in a highly reliable way, and it's not depending upon any one individual instructor. And just to add one more thing to that is that the learning experience is very individual because it depends upon what conversation tactics you select, and your virtual human will remember that. You may not see that memory come back, until several decisions down the road, but that really drives home the realism of the experience. So why virtual humans? I kind of already covered this. I mean, you feel safer in opening up. You are more likely to have reduced anxiety. It kind of reduces cognitive load, which allows you to focus more in on the learning experience. And also because of the neutrality of their appearance. In all the studies we've done, we've seen an equal effect on all races and ethnicities. We think because of this neutrality, because it lessens any transference reactions one might have as a result of a way a figure looks or maybe how they sound. So again, we see this nice efficacious impact to allow for effective transfer of learning. In the study we did, you can see the sample size was over 1,300 people, and it involved a pre-training or baseline survey where we measured two attitudinal constructs: competency, which is kind of related to how prepared you are, and self-efficacy, that's confidence in your ability to engage in expert activities. And then we measured three behaviors, both at pre and the follow-up. How many adolescents have you screened for substance use? Have you engaged in brief motivational interviewing with or counseling, and then actually made a referral based on their needs? This pre-survey was followed by the simulation itself, which was immediately followed by the post-training survey, which repeated some of the measures in the pre-survey. And then we had the 3-month follow-up, where again you're ascertaining where people reside in terms of the attitudinal constructs and were there any changes in behaviors. Next slide, please. So here we see an overview of the demographics. Just very briefly, you see that most of our participants were female. We had a good number from all ethnicity, races. In terms of job role, you see a majority of our population were either nurse practitioners, or students in healthcare. Interesting that 54% had previous FBI training, which is interesting because later on when you see the more qualitative data or the quantitative data, you're going to see that it had an impact on them also. And then 30% took the course, received some sort of credits for taking it. Next slide. So here we see the first construct, the competency measured in terms of pre-post, the impact of the simulation, in terms of how they view themselves as professionally competent in engaging in the following activities based on a Likert scale response. And we see rather dramatic increases, probability 0.001 in terms of feeling professionally competent and working with adolescents, in terms of addressing alcohol and drug related issues, about frequency, about quantity, about screening, about tailoring brief interventions to adolescents, motivational level, because you want to tap into their level so you can provide them the incentive to change, and to help them to develop a personal plan, which is kind of like part of tapping into that motivational level. And then lastly, referring adolescents that are appropriate for them based on the needs that you determined. And with all these combined, the next slide will show you that as a composite score, you see that high significance from pre-test to post-test. And what's really encouraging, there's very, very little drop-off at the follow-up, which is something that's kind of unusual, because normally we see this drop-off as being significant or near significant, and here you see a rather profound measure where it's not dropping off hardly at all. Next slide. Now we get into self-efficacy, and as a result of the simulation, participants felt more confident in their ability to screen, to provide brief motivational counseling, and to refer. You can see the percentage values there. Again, significant at the 0.001 level. And self-efficacy, probably of all the attitudinal constructs, is the most important, for it is more likely to predict changes in behavior. We always like to include self-efficacy as an important variable. And as a composite variable, again, at the follow-up, we see very little drop-off, so the learning is sustained. Next slide. Very, very encouraging here when you actually look at the differences in pre-test and follow-up measures of behavior in terms of the number of adolescents you have screened, again, engaged in brief motivational counseling and referred. Gosh, you see what's particularly kind of awesome is the 206% increase in the number of adolescents in which participants engaged in motivational counseling. It's really encouraging to see that being integrated more into practice. Next slide. Oh, there you go. Here you go, Cyril.
Thank you very much, Dr. Albright. And we will now move on to John Orwatt, who will talk about the expert at LUC implementation of this simulation within their training activities. Dr. Orwatt?
Great, thank you, Cyril. Great presentation, Dr. Albright. So, yes, my name is John Orwatt, and with Michael Dentato, associate professor here at Loyola, I'm going to present kind of how we're using Kognito within the context of a SAMHSA training grant, and kind of some of the implementation and some of the ways that we've used it. On the next slide, what you see is an introduction to our university. We're the Loyola University of Chicago, is the largest Jesuit school in the country, university in the country. We have a medical school. We have a school of social work, a nursing school. We have an undergraduate campus, a professional school campus, and a medical school campus. We are located in Cook County, Illinois, and it's a region that's characterized as biracial, ethnic, gender, and socioeconomic diversity across multiple neighborhoods. So we have a 3-year SAMHSA grant, the purpose of which is to integrate SBIRT into the curriculum of nursing, medicine, and social work, but to also engage an advanced cohort in additional practice in SBIRT in an interprofessional way. And this includes what we use across multiple strategies: classroom learning, online simulations, both adult and adolescent, using Kognito, case presentations, role play. And the next slide kind of just gives a summary of what we're doing on the different levels. So the training program includes, the ultimate goal is to train over 3,500 students, faculty, community and behavioral health professionals. And we do that on 3 different levels. The first level is foundation training. So for students that are kind of entering medical school, entering nursing school, entering kind of social work school, we provide some basic SBIRT training. The second level is advanced training for students that are focused on medical areas. So, for example, in the School of Social Work, we have a specialization in medical health, hospital social work, health social work. And those students receive additional advanced training in SBIRT, which is particularly important because, SBIRT is really great in non-specialty behavioral health sector settings. And then finally, we have an intensive interprofessional training program. They're ambassadors, and they receive a certificate of advanced brief interventions for substance abuse among minority communities program. And this advanced one is where we'll focus as we move through. But we are on this program. What we basically do is we recruit in the spring semester 10 medical students, 10 nursing students, and 10 social work students who work in teams of 3. Ideally, one from each profession, and they engage SBIRT at the beginning of the semester, and then they attend a day-long training where they have additional kind of classroom activities on, drugs, alcohol, the biology of it, the sociology of it, but also additional SBIRT training. They experience with a standardized patient SBIRT. They can practice SBIRT training with a standardized patient. The third part of that is that they go out to an agency setting. So some students go out to a medical primary care setting, and some student teams go to Catholic Charities, where they go to a dinner, a food bank, or something like that, where they actually engage SBIRT and have practice experience. And finally, at the end of the semester, what we have is we have a day-long conference for the community, and where the students not only participate in the conference as members, but they also present either in poster format or in a presentation format some component of implementation of SBIRT in some arena. Now, one of the areas that we focus on in this training program is agency level training. So we're focusing on, local agencies. We're not necessarily focusing on hospital systems, in other words. Although we do have a lot of students involved with hospital systems, we're focused on, Catholic Charities. We have some emergency department participation here, but a lot of it, we're more focused on agency setting. So with that in mind, the rationale for using Kognito on the next slide is that it's a way that people can engage the material, learn the material, practice the material, and then kind of really spend time playing with the material, if you will, as you saw earlier in this presentation. Since our goal was to train, we need to get a lot of people ramped up on SBIRT. One of the things that you might know, what you might be seeing in your own communities, is that in the non-specialty sector, the non-specialty behavioral health sector, substance use is not necessarily a part of the daily routine of the work that's being done. And so how do we kind of get faculty? How do we get kind of agencies? How do we get agency leadership? How do we get students? How do we get all of us kind of up to speed here? So what this allowed us to do was to agencies, clinicians, and leadership to complete this anytime, anywhere. It's flexible. It's transferable. So what we oftentimes hear are things like, well, this is about adolescents, and I work with the elderly, but still it's transferable. The motivational interviewing, the notion of a screen, the notion of a brief intervention, the MI is transferable to other populations and other settings. Not directly, but it's still kind of there. There's value. So, years ago, I don't know how many years ago this was, but I had engaged, I was watching some Kognito videos on suicide in the state of Illinois, and had purchased these and distributed them. They were amongst college students. I think there was a military suicide. I'm not exactly sure. But I got a lot out of it. So when this project started approaching, Kognito became a very natural partner in this, because what I really saw was value with the advanced learning and kind of practice opportunities within the tool itself, but also, some other value that often isn't realized, like CEUs, which, is always nice to get. again, we needed to train all levels in domains, but kind of capture as many people as possible on their time schedules, not necessarily ours. The idea of having a Saturday training or something for, you know, the community was not necessarily going to be the most effective way to kind of deliver this material. And finally, Kognito has embedded in it opportunities for evaluation. So not only are several of the evaluations that Dr. Albright kind of reviewed in there embedded in there, but we could also ask additional questions to evaluate aspects of our own program and kind of how it worked. So how did we, like, on the ground, how did we use this? You know, and on the next slide, what you see is, so for students, what we did was, it would be a course assignment, and it yields that certificate at the end with a score on it. So students would post that on a discussion forum, let's say, and sometimes on the discussion forum we would ask questions, additional questions about using SBIRT, either clinically or within the policy realm. So the certificate became something very useful. Instructors used it to kind of increase their own knowledge and practice of SBIRT, but also gain CEUs. It also provided a way for students to kind of have some baseline before they came to class, but even more than a baseline. It actually provided students with an opportunity to, this is what we're hearing from students and from faculty, they learned it pretty well, you know, through Kognito. So when they got to class, they could actually do some more advanced kind of work around SBIRT, and kind of actually, and the other part about it was probably that second opportunity to reinforce what is in there. Many students kind of talked about learning the language, like learning language and seeing language being used and the impact of different ways of saying things, especially those on the foundation level. Community-based clinicians, student preceptors, supervisors, again, you know, providing that flexible training, that cutting-edge material that CEUs was very valuable. But, you know, one of the things that we've learned on projects is oftentimes in teaching students some of these cutting-edge, you know, tools, is that their supervisors aren't often knowledgeable, or they kind of need some refresher or some review, so they can supervise students. And as I said earlier, there's a challenge sometimes with, there's a lack of training for those in the non-specialty sector. You know, many of us that have been trained years ago didn't necessarily receive training, or we even see out there that within some of that sector, such as primary care or like a food bank, it's not our job, you know, and how do we do this? But how do we kind of think about looking at substance use in various settings beyond you know, just the specialty sector, because we can make significant interventions beforehand. So we looked at the CABASAM cohort. Again, I mentioned the CABASAM is that advanced cohort of students where we have 10 medical students, 10 nursing students, and 10 social work students. And they engage in a series of activities over the course of the semester, which starts off with Kognito. Then they have a day-long, so then they do the Kognito, and they all come in for a day-long seminar where we focus on an additional kind of layer of SBIRT. We have them practice with standardized patients. The standardized patients are often trained with unique kind of issues within our delivery system here in Chicago. Last year we focused on opioids. So students receive some additional training on opioids. What are they? What are the big issues? And then they go out into the field and they work in agency settings or in primary care clinics in teams of 3, interprofessional teams. And then they come back and they, with a preceptor out there in the field, with a supervisor, so that way they get to process their experience. And they come back and we do the seminar, the community conference that's free, gives free CEUs. And last year we focused on opioids then too. So that's kind of what we did. And so we have a sample of students that we looked at, most of whom were social work students. Then we have a good chunk of medical students, which was nice to see, and then a smaller chunk of nursing students. One of the challenges is across many curriculums, as you know, is how do we kind of feed in some of these extra activities into packed curriculums that are sometimes, you know, classroom-based, and the students have to go to, you know, hand-washing seminars, and then they have to go into the field, and they have to get, you know, so sometimes nursing is having a little bit of a struggle. They get Kognito in other ways, but for the CABASAM, this is who we're able to recruit for this particular evaluation. What we used for measures was kind of pre and post training evaluation surveys that included demographics and previous exposure, much of what Dr. Elro talked about. SBIRT and MI related knowledge. We looked at pre and post attitudes, confidence, and readiness, specifically around screens and behavioral intervention, the BNI. We looked at competency assessments and then feedback. We also looked at qualitative data like feedback, where there's some focus groups that were run, looking at kind of what was the effect of different aspects of the training, including the simulation with Kognito. And we also interviewed Loyola at SBIRT stakeholders to include faculty, staff, and also community leadership. And what we found was, on the next slide, was the CABA-SAM findings. We saw, significant increases in knowledge, attitude towards working with people that use alcohol and use drugs. Confidence increased. We saw a significant increase in confidence as well as readiness. The average Kognito score that students received was an 84.5 out of 100. So a lot of these increases are about CABA-SAM, the whole program, not just, we're not just isolating Kognito here. But the average score that we did see with students was 84.5. So students were challenged by Kognito. This wasn't something that they could just kind of whip through, if you will, and experience. We also found that at times that some students said that they would do it a couple times, and that was also something that some students found useful, because there is a different experience of it, each time you do it. The value that we saw on the next page, and there's some interesting value that we found, some of which I already mentioned, was constantly getting feedback that people are able to have that practice of the brief negotiated interview. It's not in motivational interviewing. It's not just something that people receive. They can actually engage something, and based on how they engage that patient, it kind of leads them through a path to understand. Again, practicing the language was something that students found very helpful. The performance feedback with the virtual coach and skills assessment. So, there's a point sometimes, and I know when I was doing this, where you actually get feedback right away. This is inconsistent with how we might understand stages of change and stuff like that. And that's very, very helpful. The reinforcement of knowledge. Some faculty talked about, and I thought this was great too, sometimes face-to-face isn't possible. So even in the classroom setting, faculty might have an SBIRT lesson and, something happens. I don't know, it snows or they're out of town or something like that. Or there's a training within an agency, and face-to-face just isn't possible. There isn't time. So it's a great activity to do where students can actually practice something, receive a certificate, demonstrate, the level of competency that they achieved doing this. And also the evaluation that we received back has also been very helpful for us in kind of thinking through our evaluation and implementation cycles. We also, there's another piece of this, in this kind of straddles into the next slide, but we really wanted to increase uptake by clinicians, and what we found that we really had to do is that everybody does it. So project leadership, faculty do it, our council of directors do it, everybody does it. And that led to significant feedback that we found really helpful about the delivery system and in Chicago that helped us as we move forward. So it was important that leadership understand what SBIRT is, because that kind of guides their decision making about where to think through where SBIRT should go within, let's say, their agency setting. So at first what we would hear is people say things like, well, we don't have a substance abuse treatment unit, so we're not going to do SBIRT. And then we had to say, well, actually, that's not what SBIRT is. SBIRT is actually ideal for your particular situation, such as the food bank at Catholic Charities or a couple of other organizations, So what we received was really interesting feedback from caseworkers and other folks at those settings that talked about kind of the interventions for alcohol, for example, that doesn't reach like a diagnosable or referral level, but the brief interventions that were received seem to have an effect on people and seem to open up that conversation within those non-specialty sectors. There's no need necessarily for some of the folks that were at some of these locations to actually engage the specialty sector system. You know, that hasn't reached that level, but we don't want it to reach that level. So we engage in those stages of change really helps. But we also learned other things such as referral for treatment can be challenging for some organizations because there may be beds theoretically, but getting people to those beds is challenging because they're on the other side of town or because they cross certain lines in neighborhoods that can't be crossed by certain people and stuff like that. And that kind of data and that kind of information really helped us to understand what does this look like on the ground, our overall delivery system. So the next slide, I sort of talked about a little bit about some of those other suggestions. I might repeat myself a little bit, but to get people to do it, you know, so regarding uptake, for students we made it mandatory. And again, the certificate provides a unique opportunity, but the other thing is that word of mouth provides a great opportunity. And that's with the shaking hands thing, is I always encourage students to get their classmates to do it, to get their friends to do it, to get their classmates at, you know, other social work schools to do it. You know, I'll show up with brochures in class and I'll hand them out, you know. And our CEU office does the same. There's often kind of a place there where there's a link there, so that way community leadership, when they say this is really good, I want all my clinicians to do it, or I want a agency head across town to do this, can send that link over. And part of that shaking hands too is we have an email that we send out to people that they can easily forward to their colleagues to again get not just clinicians doing this, but also, you know, agency leadership and community leadership. A big hook is the CEUs, especially for the clinicians in the group. The SBIRT training, a lot of people in the community have heard about SBIRT. They've heard about kind of the importance of screening and brief interventions. They've heard things like some of their own education around substance use is kind of has changed to include things like motivational interviewing and stages of change, and you know, this idea that people don't have to hit rock bottom to, you know, and so that this provides people, again, that flexible kind of opportunity to learn this, but also practice this. The other hook that's interesting, I think, is it's just a unique online educational approach. And so there are some folks out in the community who I know are just kind of techies, if you will, and you're just kind of like, just check it out. Like, I'm just curious to see what you think as a techie person. Like, do you think this actually kind of straddles technology and clinical learning and stuff? And that has been an interesting hook for people. And in fact, one of my, when I teach policy class, in one of my classes, we actually talk about that. Is this a viable kind of method of teaching people in the community? And does it actually kind of, how do we understand the method deployed kind of theoretically and stuff like that? So, I said this earlier, but everybody completes the training, especially the project leadership. It just helps to get the word out there. It adds like this layer of emotion to it. So, you know, Michael and I, the co-PI on this project, and we were like, everybody do Kognito. And then we finally did it too. And it was a very different approach to encouragement at that point, because we're like, this is cool. Do you know what I mean? And we learned a lot from this. So that's always a big suggestion for me, is everyone does it, because everybody kind of gets it. And it is something that's unique. So to me, what's unique about this is we're getting the word out there about this, how we understand substance use differently, how we understand interventions, that we don't have to confront people anymore, that we can intervene when people are starting to hit hazardous rather than, you know, hit, clinically significant, but also, you know, how do we kind of engage in our clinical knowledge and changing our clinical knowledge in a way that's different. So that's I have was for today. I think that covers it.
Thank you so much, Dr. Orwat. Very, very interesting presentation. It's great to have a sense of how this is being deployed in the field and integrated within your training activities. Thank you very much for your presentation. I want to remind all participants to please submit questions if you have any. We're now going to open the floor to have a little Q&A session. We've had a few questions submitted already. The first one, I think I'm going to ask Dr. Alwat to answer it. The first question is, how appropriate is the SBIRT process to address opioid misuse? Would you like to answer that, Dr. Alwat?
Sure. And I have a couple of thoughts around that. The first one is kind of a more general thought. And SBIRT, the Kognito SBIRT with adolescents does a really good job of kind of teaching a specific screen, teaching a specific BNI, and stuff like that. But there are different screens, and there are different kind of approaches. And so learning a couple of them is really good, but also thinking through, okay, what's going on with my particular population that I'm serving in this agency or within my community? And then kind of thinking through, what screens do we use? Where do we start? What kind of interventions do we use? And so the opioid issue is an important one, because this, of course, especially in our area, has come up. So we've had to kind of, in some ways, help our community, and work with our community, I should say, not help, but work with our community to identify, what are the specific issues around opioids? How does that change how we screen? How does it change how we do interventions and stuff? So we've supplemented SBIRT with training around opioids. So is SBIRT been, do we have RCTs and everything else that SBIRT is totally, working for opioids, and this is what we do and this is what we do? No, but in some ways we also don't have RCTs that parachutes work. So it doesn't mean you should jump out of a plane without a parachute. So the idea is that, how can this provide the platform from which to operate for many agencies, and many of whom they're not even services available, but you can also intervene sooner in the trajectory of use to misuse. So does that answer that, Cyril?
Yes, absolutely. Thank you very much, Dr. Alwat. And I really like your analogy of the parachute. That's a great example. The second question, I think I can answer this one actually. The question was, do you have any thoughts about using simulations to train nursing and allied health profession students to prepare them for the role that they can play in substance use disorders or preventing substance use? Yes, in fact, this simulation has been used by many nurses out in the field, as well as by schools of nursing around the country. In fact, you can play this simulation as a nurse. We showed you the social worker version today because Loyola was our guest speaker, Loyola School of Social Work, but you can actually play this simulation as either a social worker, a nurse, or even a physician. And so this is highly appropriate for all of those types of professionals. We have a final question, which I think I'm going to call on both our speakers to answer, which is about the applicability of SBIRT for parents, and what are the skills that parents can learn and practice and apply in conversations, for example, with their children. Would you like to speak to that, John?
Sure. And I'm glad that you thrown it to both of us, because I remember what's great about this question is it seems to be really on the cutting edge, because it came up before too, which is really exciting. And I know Dr. Albright had some great insight into this. I think it's an interesting question. I think it's an interesting opportunity for parents to kind of think through how to respond to substance use with their children. I think that the overall, in that question earlier about other allied health and stuff, is an important one. To me, everybody, I don't mean to minimize this, but this is in some ways a public health intervention. Do you know what I mean? So the idea that kind of everyone has a sense about how do we approach substance use in people, parents, dietitians, nurses, physicians. I think thinking through actually having parents watch this and how that might change their understanding, that's a very interesting kind of study, even if it's just an operational type thing.
Glenn Albright here. So my thought about a response to that question is, being a parent who's had to deal with this type of situation is hard. And you can take advantage of any help you get, because when you are in a situation that involves someone you care about and love, sometimes MI skills have the chance to escape you if you don't have enough confidence in them and skill in them, and in this case, practice. So it's so easy for parents to be judgmental, to be critical, and we know that that's not effective, and often that drives the adolescent further away from you and makes the problem even worse and less approachable. So just being aware of this has helped me significantly in terms of being patient and listening and not being, jumping to conclusions. And I find this with other parents I know, where I see both sides of the spectrum. I see them come down really hard and lay the law down, and it has had the exact opposite effect, and it just renders havoc in the family, as opposed to those who seek guidance in terms of how to best approach this and learn just basic MI skills, which helps in any relationship, frankly. So the answer to that question is very easily yes. SBIRT does generalize over into numerous areas. Thanks for asking the question, whoever did.
Thank you very much. Yeah, I think what I'm hearing from both of you is normalize substance use conversations. I think that's something that SBIRT does extremely well, is to take away the stigma of talking about substance use and normalizing conversations, not just with healthcare professionals, but also out in the community. B, we would want to implement positive communication techniques, collaborative communication, rather than kind of berate people about substance use as we have done historically for many years. And 3, giving parents or anybody in the community the ability to practice these conversations and become more confident will be key in helping them navigate them. This was our last question, so we are going to wrap up this session for today. I just want to remind participants that you will all receive a copy of the recording and the slides in your email later today. I just want to vigorously thank my 2 main speakers, Dr. John Orwatt from Loyola University Chicago School of Social Work, and his co-PI, Michael Dentato, who has been collaborating with him on this initiative, and my colleague Glenn Albright, co-founder and director of research here at Kognito. Please do get in touch with us via email if you have any questions for the speakers or for Kognito. Thank you all again for joining today, and we'll see you on the next webinar.